Hi, everybody. It's a great pleasure to be with you today to give an HHT awareness talk. This is a topic I'm very passionate about and was very excited for this opportunity to talk to you today. In fact, as I got going thinking about it, I thought I'm going to tell them about the 10 things I want the world to know about HHT. But then I realized that that might take a little bit longer than everybody's prepared to listen for. And so I thought I should focus. My apologies. Here we go. I thought I should focus on the three things I want to tell the world about HHT. But in fact, I couldn't fit it into three, so it's going to be four. So this is my plan today is to talk to you about the four most important things I want the world to know about HHT in 2023. So the first is that it's not that hard to diagnose HHT. HHT, or Hereditary Hemorrhagic Telangiectasia, is a rare disease and unfortunately remains underdiagnosed. It is, however, characterized by some very typical blood vessel malformations and some very typical symptoms and signs that I'm going to walk through to make my case that HHT is not that hard to diagnose and we should be able to address the underdiagnosis issue. So as you can see in this slide, HHT is characterized by small vascular malformations, which we call telangiectasia. And here you see some typical ones on this patient's finger and also on the lips and on the tongue. And also some telangiectasia in the organs. This is a telangiectasia in the digestive tract or the gut. And these are some larger telangiectasia in the liver on an angiogram, and finally, even larger malformations that we call arteriovenous malformations. These are in the lungs and this angiogram on the right, on the bottom right. So these are the typical lesions that characterize HHT. The most common features of HHT that a doctor will be able to use to help diagnose HHT, or that people who have HHT will be able to bring to their doctor in the hopes of getting their diagnosis clarified, are the telangiectasia of the skin and mucosa that I've just shown you, which are present in about 90% of adults by about age 50. The symptoms and signs of HHT, particularly these common features of HHT, do appear more with age. And so if you look at 20-year-olds, only about 50% of them have telangiectasia like this on the skin and the mucosa meaning lining of the mouth and nose, whereas by age 50, it's 90%. The same is true for the nosebleeds. Eventually, about 90 to 95% of adults with HHT have frequent, recurrent, spontaneous nosebleeds, or what we call epistaxis in medical language. So these are the very common and typical features of HHT that underlie the diagnosis of HHT that doctors can make and confirm in the clinic. So these the features that are required to assess someone or to make a clinical diagnosis of HHT include the nosebleeds, the epistaxis, the typical telangiectasia, and also the presence of organ AVMs. Finally, the fourth criteria for diagnosing HHT clinically is having a family history, typically in a first-degree relative. So these criteria for diagnosing HHT clinically have been well described, and they're called the Curacao criteria, and they were published more than 20 years ago. And they were upheld more recently in the International HHT Guidelines. So how do we apply these criteria? Well, when three or more of these criteria are present, we call that a definite clinical diagnosis of HHT. When there are two criteria present, we call it a possible diagnosis of HHT. If there's only one, it's an uncertain diagnosis of HHT. And notice the wording here. It's not that we say that we've ruled out or that there clearly isn't HHT, but just that it's uncertain when there's only one criterion. HHT can also be diagnosed using genetic testing. And this is based on the fact that 90% of HHT families have a mutation in what's called the endoglin gene or the ACVRL1 gene. There's also a rarer mutation, a rarer gene, which can be affected in about 3% of HHT families called the SMAD4 gene. And those people often have actually two diseases. They have HHT and another disease called juvenile polyposis. So when we're using genetic testing for HHT, the first step, there are actually two steps involved. The first step is to identify the mutation, the HHT mutation that exists in a given family. So usually we start with someone that has a definite clinical diagnosis. And we say, okay, we know this person has HHT. Now let's draw blood on them and go and analyze their DNA and figure out if they figure out where their mutation is that causes their HHT. And the reason we start in someone who has a definite diagnosis is because genetic results are actually difficult to interpret. There's a lot of abnormal variation in genetic results and in genetic codes. And so it's very important that when the person we start with is someone we know has HHT, and when we find changes in the HHT genes, that we're able to assess them, knowing and to determine whether those are disease-causing changes, in other words, mutation, or whether they are normal variation in the genetics. And it helps us a lot if we start with someone that we know is HHT, so we don't make any mistakes in our conclusions about disease causing versus normal gene changes. The second step, once we've identified, the second reason we need to identify the family's HHT mutation is that almost every family has a private mutation. So though most of the mutations, as I've said, are in either the endoglin gene or the ACVRL1 gene, the actual mutation or change in code in the gene is different for each family. But once we find it for a given family, then everyone in that family that has HHT will have that exact gene mutation. So step 2 is to check for the family's mutation in other people in the family, particularly people who have an uncertain or possible clinical diagnosis. In other words, we're not sure whether they have HHT or not, even though we know HHT is in the family. So that's when we want to use genetics to help sort out those people where we have an uncertain diagnosis. So we have two good ways to make the diagnosis. First, the clinical diagnosis, which I've described in detail. And secondly, using genetics to help sort out other people in the family. Important thing number 2 that I want to tell the world about HHT is that prevention is paramount in HHT. I'm going to give you an example of one of the clinical situations or one of the indications for prevention in HHT, which is to make my case. It's a very clear example, and that's about and it relates to arteriovenous malformations, or AVMs, in people with HHT. So AVMs are the abnormal blood vessels that can occur in the internal organs in people with HHT. And unfortunately, these are often unrecognized features of HHT. So people don't even know that they have them. They might know they have nosebleeds. They might have noticed they have telangiectasia, but they don't know that they have AVMs in their lungs, for example, or other organs. And so these AVMs often go unnoticed until the day that they cause a serious complication. However, though these are often unrecognized, they are not uncommon. In fact, they are common features of HHT. And here's in this table on the right, you can see how AVMs can occur in multiple organs and not infrequently. So about 10% of patients with HHT will have AVMs in the brain, 40% in the lung, 20% in the gut, or what I will call GI tract, which means stomach and bowels, and 75% in the liver. The issue with organ AVMs, sorry, I'm having a little trouble with my screen here. The issue with organ AVMs is that they are common, and also the important clinical piece is that there's a role for prevention. So as I mentioned, people often don't know that they have them until they cause a complication. But we can detect them ahead of time and prevent those complications, particularly as it pertains to lung AVMs and brain AVMs. So let me give you the example of a lung AVM and how we would prevent complications. So this is an image of a typical lung AVM. And an AVM is really a direct connection between an artery and vein without any of the usual capillaries in between. And this is an angiogram image of a typical lung AVM, where you can see the red arrow pointing to the artery of the AVM. And then the yellow arrow points to the aneurysm of the AVM. And then finally, the draining vein of the AVM. So the blood flows through the artery, through the aneurysm, and back through the draining vein back to the heart, without ever going through any capillaries. And this is really what defines an AVM, is a direct artery to vein connection. And that's an abnormal thing. There should be capillaries in between. So the issue with AVMs in the lungs is that they can not only bleed into the lungs, but even more frequently, they can cause brain complications because of the loss of the filtering capillaries in the lungs. So brain complications can include stroke and brain abscess. And stroke is, in fact, the most common complication of lung AVMs. So brain complications are the most common complication of lung AVMs. That's the bad news. The good news is we have a really safe and effective treatment for lung AVMs. So if we can detect them in someone with HHT, and as I'll tell you shortly, we do know how to do that, then we can treat it with a procedure called embolization. So it's a procedure, it's not a surgery, it's low risk, it's very safe and effective. Here's a picture of a large AVM. This is an angiogram, what we call it. It's an X-ray where we're injecting dye to light up the blood vessels. That's what angio means, is blood vessels. So here's an example. This is the right lung of this young man who actually presented, with a preventable complication. He'd had a brain infection due to his lung AVM. So this is his angio on the left here, and the dye is going through the artery of the lungs. And normally, and you see all these normal areas which branch out like a tree, but down here in the bottom half of the lung, you see this large AVM where you have an artery, multiple aneurysms, and draining vein. So this is before treatment. And then on the right-hand side is the angiogram after treatment, where you see the injection into the artery, and then every artery feeding this AVM. As I mentioned, this is a big AVM, but it makes it easy for showing to you. Every artery feeding this AVM is now blocked with coils. You can see the little metallic densities, and there's no blood flow now making it to the aneurysms. You see how they're invisible here, and nothing going to the draining vein. So with embolization, we block off the artery that's feeding the lung AVM. And now the blood goes to normal areas where it can get filtered and oxygenated, and the patient is no longer at risk of brain complications or hemorrhage. Important thing number 3 I want the world to know about HHT is there are clinical guidelines for HHT. There was a time when people would say, when healthcare professionals would say, well, it's unclear how to treat people with HHT. It's unclear what testing they need. That is no longer the case. We have international guidelines for the diagnosis and management of all aspects of HHT. This photo here is from our second International HHT Guidelines conference, which took place in Toronto in November 2019. And we had people, including experts in all relevant areas of HHT, and patients with HHT from 15 countries participating in this process. It was a really spectacular effort. And as I mentioned, it was the second international guidelines. We had done the first one about 13 years prior. So the international guidelines that came out of this, this huge international effort are freely available online. They're published in a high impact, widely read medical journal called the Annals of Internal Medicine. As I mentioned, international 15 countries agreed to these guidelines, and they address all aspects of HHT, and they really are relevant for the care of everyone with HHT. This is an example of the guidelines approach to lung AVMs, given that I've just talked to you about lung AVMs and how they should be treated. So each one of these statements are sort of summaries of some of the recommendations that are in the international HHT guidelines regarding lung AVMs. So first, all people with HHT should be screened for lung AVMs, even if they don't have symptoms. In fact, preferably when they don't have symptoms. And that typically the recommended test for screening is called contrast echocardiography, or bubble echo. Some of you might have heard that term as well. The second recommendation related to the approach to lung AVMs is that lung AVMs should be treated preventatively with embolization, as I've just shown you. Not wait for complications, not waiting for symptoms, but treating preventatively before lung AVMs cause problems. And that the third recommendation is that people with lung AVMs, even after treatment, should be followed long-term. In addition to the International HHT Guidelines, or as I guess as a partner to the International HHT Guidelines, we developed these HHT care checklists that are related to all the aspects of the guidelines. And we did this with Cure HHT, and Cure HHT has made all of this information available, the guidelines as well as the checklists about different aspects of HHT on the hhtguidelines.org site. Important thing number 4 that I really want the world to hear about HHT is that bleeding in HHT is treatable. People with HHT can have bleeding from the nose, as you've heard, most adults do, at least eventually. About 20% of people with HHT, particularly older adults, can have chronic bleeding from the GI or gastrointestinal tract. Whether it's nosebleeds or GI bleeding or both, people with HHT can have mild, moderate, or severe bleeding. And often their bleeding affects their quality of life and can cause them to have anemia, which means a low blood count with a number of symptoms, including fatigue and sometimes shortness of breath and other. So all of, so nosebleeds in HHT certainly impact people's life, and both medically and in terms of their quality of life. And for a long time, we've heard from many people. In fact, I still sometimes hear this from my patients, and sometimes I think they're hearing it from their family members or from their healthcare workers that there's nothing that can be done for their bleeding. And we must no longer say that, and we must not accept that. We do currently have therapies for bleeding in HHT, and there are a lot of new therapies coming down the pipeline. So there's a lot of reason to be hopeful here. And I think it's super important that everybody in the world hear that there is something to be done about bleeding in HHT, and that people with HHT who are bleeding, they need treatment, they need help. So what are the current medications that are, for example, detailed in the HHT guidelines for HHT bleeding? There are a number of them, and I won't go through all of them in detail, but they do range and include things like nasal lubrication for very mild nosebleeds, to topical medications or medicated nasal ointments as often a next step. And then there are some medications like tranexamic acid, which can be taken in a pill form when people have nosebleeds that continue to be problematic despite those topical approaches. And then the medications range all the way to a medication for more severe bleeding called bevacizumab, or some of you may have heard of it called Avastin, which is an intravenous medication that can be effective for severe bleeding in HHT. There are also, other ways to treat HHT, including endoscopic and surgical therapies, and always important to treat the anemia and iron deficiency related to HHT bleeding. So this is sort of the currently available medications where we have enough experience that there are recommendations in our international guidelines. But I want to talk to you about also what's happening and what's coming for the future. So there are new therapies coming to HHT, and they are going to be largely based on observations that we've made and new things we've understood about the mechanisms of disease in HHT. So here I'm going to show you a slide from 20 years ago that I pulled up that was a summary slide about what we knew about the mechanisms of HHT. In other words, what causes the abnormal blood vessels in HHT. And at that time, we had already known for a few years what the genes were in HHT that I've already mentioned to you. Endoglin, ACVRL1, and SMAD4 are the genes that can typically be mutated in HHT. And we knew that they were all part of this pathway called the TGF-beta pathway. And that's a pathway, a molecular pathway inside of our cells that's involved in blood vessel growth and development. And so it made sense, scientists and clinicians who were interested in HHT said it makes sense that these genes are affected in HHT, but we really didn't know much more about how the gene mutation led to the malformations and bleeding in HHT. So that was about 20 years ago. And then soon after or around that time, I should say, Michel Letarte, who was a PhD scientist and one of the first to really dig further into the mechanisms of HHT, she studied endoglin. So she studied the protein that's made as a result of that comes from the endoglin gene. And she discovered that in people who have HHT and who have a mutation in the endoglin gene, that they had less endoglin on their endothelial cells. The endothelial cells are the cells that line the blood vessels in HHT. And this was sort of one of the first important steps in understanding the mechanisms that came after learning about the mutations. But we still had a long way to go. Really, what we understood was what genes were mutated, how that was reducing the protein on blood vessel cells. So made sense. It was the right pathway, a pathway that made sense that was affected. It was a cell that made sense that was affected, but we really didn't have much more to go on. Now I want to skip forward and show you how scientists think now about mechanisms in HHT. And I'm not going to go through this whole diagram, but more I wanted to show you just how complicated it is and how much more the scientists have learned. So first of all, here's endoglin, ALK1 or ACVRL1, same thing, and SMAD4. So you know this piece already. And they're all part of this TGF-beta BMP9 pathway. And that pathway continues to be important in HHT mechanisms. But we've also learned that there are other pathways involved, including this whole pathway over here. And we've learned about other factors that allow communication between these pathways, and also some of the factors back down into the nucleus of the cell that affect how genes are processed in people with HHT. And then in addition, there are a couple of comments up here. These scientists in 2022, when they were reviewing the mechanism, they also brought in some new information about how the dynamics of blood flow the dynamics of blood flow within blood vessels also affects the development of AVMs in HHT, as well as how cells respond to the environment with these mutations and with the blood vessel dynamics that they're living with. So it's a complicated model, and this is really, though, the understanding these mechanisms and that they involve more than one pathway, that they involve cell responses and blood vessel dynamics, this has really opened up a lot of avenues for us to understand and explore new therapies in HHT. And this is another diagram that I'm not going to walk through all the details of, except to show you that this is another HHT scientist sort of view of the HHT mechanism. But what Dr. Marambo did is he put in all the drugs that we're interested in that can affect different aspects, different targets within the pathways that we've identified, and other cellular responses that have been identified in the HHT mechanism. So as you can see, there's quite a long list of medications in this diagram, and it's a very different picture than those first couple of slides I showed you. So, understanding these complex HHT disease mechanisms has opened up many possible targets for therapy. And in fact, there are a number of ongoing clinical trials in HHT in the past few years. And if you had asked me 5 years ago what clinical trials are going on in HHT, I would have said none. This is really a new era for HHT care. So this is the list of current medications in clinical trials across the world, but there are others that are being planned as we speak, and that you can always keep up to date about if you look on clinicaltrials.gov. So that's an excellent place to go to. You can just search using HHT in clinical trials, and you'll find what's going on and which trials are recruiting people with HHT and what drugs are being considered. So to summarize, my messages to the world about HHT are the following. First, it's not hard to diagnose HHT. We should be able to address the underdiagnosis problem and make sure that everyone who has HHT knows they have it, because if you have HHT, prevention is paramount. It's really important to know who has but in a given person with HHT, whether they have lung and brain AVMs, as we have preventative therapies to offer. Number 3, there are HHT clinical guidelines. They're widely available, internationally agreed upon. They set the standard for HHT care. And it's really important for healthcare professionals and HHT patients to be aware of those and to have them and to access them as part of their care. And that's why they're made available at hhtguidelines.org. And then finally, the 4th is that bleeding in HHT is treatable. We have some current therapies, and we have a number of new therapies that are being tested for bleeding in HHT and that are really promising. So I want to close by saying the future looks bright for people with HHT, and I think awareness about the disease is a really important part of that bright future. And I want to thank HHT Canada for inviting me to give this talk, but also for making the world more aware about HHT. This is super important, and I'm really happy and honored to be part of this initiative. I also want to thank HHT Canada for all the work they've been doing in recent years to educate people with HHT about the disease, and clinicians with HHT. To educate people with HHT about the disease, but also clinicians about how to care for people with HHT. And I've heard that HHT Canada is looking for new board members, and so I would encourage anybody out there who's interested in being part of this cause and helping move this really important cause forward to reach out to HHT Canada. Thank you so much. I'm happy to answer any questions.
Hi, Dr. Faughnan. Thank you so much for your talk on HHT and introducing the 4 key takeaway lessons. I was just wondering, I had a question. You mentioned the importance of screening for lung AVMs. I was wondering for clinicians or other patients with HHT listening, when they should seek out AVM screening of other organs, such as the liver and the brain.
Great question. So let me start with lung AVMs, because I didn't talk about when. I think that any time of, at the first moment when someone is diagnosed with HHT, they should be screened for lung AVMs. So there's no reason to wait. And then if that screening is negative, it should be redone every 5 years for life. For brain AVMs, same starting point, whether it's a baby or an adult, when the person is diagnosed with HHT, they should get screened for brain AVMs. And usually we recommend if screening is starting in childhood, that it be repeated, and if it's negative initially, in other words, no brain AVMs, then it should be repeated every 5 years until age 20, and then it doesn't typically need to be repeated after that. The other organs are a bit different. So because we treat lung and brain AVMs preventatively, we always want to do very sensitive testing to look for them. So like the bubble echo for lung AVMs or the MRI for brain AVMs. For liver, for example, we treat liver vascular malformations in HHT when they cause symptoms. So though when we first see someone with HHT, we'll ask them about symptoms of liver vascular malformations, and we'll examine them for any signs of them, and we'll do some basic testing, like including blood work and often ultrasound, to see whether they have evidence of liver vascular malformations. We don't often need to do like an MRI for example, if the person isn't having symptoms.
Thank you so much, Dr. Faughnan.
My pleasure.
Hi, Dr. Faughnan. Thank you so much for your wonderful talk. I just had a question for, I guess, on behalf of patients who already have an existing diagnosis of HHT. Are there any kinds of lifestyle interventions, whether it be, diet or exercise, that they should really try their best to keep up with? And for that matter, is there anything that they should avoid?
Great question. And there isn't a lot of scientific research that's been done to answer your question, but there's quite a bit of kind of logical clinical experience that I can use to help me answer. So first of all, one of the things that does seem to trigger, and we honestly learn this from our patients, but one of the things that seems to trigger nosebleeds and often make them worse is alcohol. So we don't tell all our patients you can never drink alcohol, but we say, you know, if someone's having a lot of nosebleeds, we'll say, hey, you know, maybe you should, and if they're, you know, depending on how much they're drinking, we'll often recommend that they cut back on alcohol, or that they try a period of time with no alcohol to see if that helps their bleeding. Everyone reacts a little bit differently, but alcohol seems to be one of the clearest cut associations with triggering nosebleeds in particular. Otherwise, with foods, they're, you know, again, people react differently. So often what we suggest is, you know, instead of us saying, you know, these are all the 100 things that could theoretically affect nosebleeds in someone, will say, hey, why don't you, you know, keep a notebook about what things you think might be triggering your nosebleeds, and then you know, you can work with us to try and test those things, you know, to see whether they might in fact be making your nosebleeds worse, or if you take a break for them, do your nosebleeds get better, etc. So sometimes people have to do a little bit of their own experimentation to figure out some of the other food triggers, but there's no clear there are no foods that clearly across the board make people's nosebleeds or other HHT symptoms worse. And then the final piece is, you know, what other advice in terms of exercise and other lifestyle advice. You know, I think the more that someone with HHT can do to lead a healthy lifestyle, then the healthier their blood vessels and the less likely they are to have complications, because healthy blood vessels don't bleed as much. They're less likely to form clots and lead to things like stroke, for example. So you know, we recommend things like regular exercise and no smoking and trying to keep a healthy body weight. You know, things that are all, you know, that are helpful in terms of preventing a lot of different disease, and that are not always easy, but are important lifestyle measures to consider, even in HHT.
Awesome. Thank you so much for your answer. And again, thank you so much for your insights on HHT.
No problem. My pleasure.
Hey, Dr. Faughnan, thank you for the incredible talk. It's always a pleasure to have you on.
Thank you.
I just had a question about the diagnosis of children with HHT. So I think it was said that, like, as age increases, a higher percentage of people will get telangiectasias and nosebleeds and so forth. But how might a concerned parent find out if their child has HHT if those children are less likely to present with those typical signs? Should they undergo genetic testing or anything else?
Yeah, that's a great question, and a really important one, because even though children can sometimes not have the nosebleeds or telangiectasia, and they might only develop them in adult life, they still could, they could already have lung AVMs or brain AVMs. And so we don't want to rely on nosebleeds to tell us when somebody has HHT within an HHT family. So once we know that a family has HHT, then we really recommend that everyone in the family get checked out. And so for children, the way it often happens is that, you know, one of their parents has HHT, and actually often we'll be having this conversation even before a child is born. We'll be meeting with the parents and saying, look, your baby has a 50% chance of having HHT. So let's make a plan now to figure out how we're going to get the genetic testing done on your baby so that we can find out right away at birth or very soon after whether they have HHT or whether they don't have HHT. So if let's say mom has HHT, we can do genetic testing in her, find the mutation that causes her HHT, and then we can plan to test the baby typically at birth, like it can be done on cord blood. So they just draw a sample from the cord blood at birth, and that goes off to the lab, and the genetic lab looks for the specific mutation that's present in the mom. And either that mutation is there or is not. And if it's not, then everyone can celebrate, and that child will never have HHT. But if the child has the mutation, then we know, okay, this child's going to need to be checked out for lung and brain AVMs during infancy and followed at the HHT clinic, even if they don't have any symptoms, maybe even till adult life.
That makes a lot of sense. Thanks.
Thanks.
Thank you for your presentation, Dr. Faughnan. It's always a pleasure to have you. I'm going to end with one final question. Is it possible to have HHT with no family history?
Great question. Yes, it is. It turns out that about 4% of the people that we diagnose HHT, and like, let's say we've, you know, when we're finding we're diagnosing HHT and it's the first person in the family, 4% of those people will have HHT and I'm not explaining this well, 4% of those people will be the first person to have HHT in their family. It won't be inherited from their mom or dad. And we'll know that typically because we'll take a family history, we'll do genetic testing in the family, and we'll say, hey, turns out that nobody else has this, brothers, sisters, parents, nobody else older or in the same generation has this mutation. And so then what we assume must have happened is that genetic mutation must have developed in utero, like when that person was developing before birth. And, a genetic mutation, and I say this for the others, because I know you know this, you know this well. A genetic mutation is basically an error in the gene. And so it's an error of development or an accident that happens during development that gene gets mutated. And now this person has HHT. Now, even though a person can have HHT and not have inherited it from their parents, that doesn't mean that they won't pass it on. I mean, that person, just like anyone else with HHT, when they have children, each child has a 50% chance of inheriting the mutation. So it is a rare thing, but it does come up. Sometimes we do see this.
Thank you so much. Thank you so much for your presentation. On behalf of HHT Canada, we really appreciate you for your time and for all your insights.
It's a real pleasure. Thank you.